Okay. So thank you so much, everyone, for joining us tonight for our online forum on staying safe while you consider reconstruction surgery for breast cancer patients. We're so happy that you're here with us tonight. It's nice to see everyone. And like I always do before all of our online educational events, I want to remind everyone that we're still open. We're still here supporting breast cancer survivors. We're offering individual counseling and group counseling virtually and on the phone. We're still helping women find low and no cost mammograms. And of course, our amazing hotline volunteers are still talking to people about their concerns about breast cancer. And actually, they're the reason that we're doing this program is because they've been getting so many phone calls about people who are concerned about having surgery. So we're here for you. If you need us, please feel free to reach out to us. Just a couple of housekeeping notes. Please remember to mute your microphone, and you can choose whether or not you want to have your video going or not. We'll have a bit of time at the end for questions, which you can put in the chat box, and then I'll read them at the end for Dr. Douglas, just for simplicity. I'm now honored to introduce Dr. Barry Douglas as our speaker tonight. He is a longtime friend of our program. We were just talking about what a fantastic artist he is and how he made such beautiful bras for our Creative Cups program. He's been working with Long Island Plastic Surgery Group since 1971. He is a Phi Beta Kappa graduate of Trinity College in Connecticut, where he majored in studio art and physics. He then obtained his MD degree from Bowman Gray School of Medicine of Wake Forest University in North Carolina in 1980. After his internship, he completed his general surgical residency at Mount Sinai Hospital in New York City. Continuing his education at Mount Sinai, Dr. Douglas completed residencies in microvascular surgery and plastic surgery. We know that he does lots of other wonderful work, and we're just so fortunate that he was able to come this evening and share with us the safe practices that are happening in his office and how he's able to help patients who are coming back. So thank you so much for coming this evening to speak with us.
You're very welcome, Erin. Thank you.
You're welcome. Perfect. And just let me know when you need me to move the slides forward, okay?
Okay, so I have no ability to advance, correct? Okay. Welcome, everybody. So I'm going to go over some ideas and concepts so that you feel comfortable when considering breast reconstruction in this trying period. So we can advance to the next slide. And by the way, I've been with Long Island Plastic Surgical Group since 1991. I thought I heard you say 1971. Is that possible? No?
I don't think so. If I did, it was a very bad error. Sorry.
That would put me up to about like 90 or something like that. Not quite.
Yeah.
So this was taken several years ago with one of my Creative Cups because I really felt that these endeavors had been really important. It brings out a lot of the creativity in people in sharing their ideas and really helping women who I salute, the survivors and those going through these difficult times of diagnosis and treatment. So this was my one of my Creative Cups. I've done 3 and it's been a lot of fun. So I hope the program gets restored because it certainly is a challenge to come up with something creative compared to some of these other people coming up with just amazing ideas. It's really quite wonderful seeing this. So next slide. So the COVID, the coronavirus, has obviously changed life as we know it. First and foremost is we want everyone safe. We want the patients safe. We want our workers safe. We want the physicians and our staff safe. So based on the phase that we are in, as we're entering another phase Wednesday, we have been ramping up the office situation and ramping up the operative situation. So when it was really closed down, there was really nothing much going on at all, which was problematic for people that had a new diagnosis and they were being told, well, really no elective surgery is being performed at any of the hospitals unless it's really emergent. And it was very disconcerting because patients needed to get these procedures done. So fortunately, when the ASUs, the ambulatory units, started coming back online, meaning that it was safe to proceed with elective surgery, the backlog cases came back on. So in terms of the appointment, so you make an appointment for the physician. There's really nothing much that you have to do beforehand, except when you show up, we just do a temperature test with a thermal scan where they point something at your forehead and they just give you a readout. So they also ask you some perfunctory questions as to whether you have any kind of symptomatology. And between the mask that you're wearing, which are very important, and the social distancing, that's really all that has to be in the back of your mind. And in order to keep the flow as uncongested as possible, the biggest change in our practice since the phase has been lifted for us to see patients is that we have given more time per appointment so that we don't have people double booked, banging into each other on the elevator in the waiting room and causing problems with too much contact unnecessary. So that's what's being done now. You make your appointment, you're given a large enough block time so that the amount of interaction with other patients is fairly minimal. You're practicing social distancing and you're wearing a mask, as we are also. And the thermal scan is at that bottom right part of the slide. And it's fairly accurate, but most people are at like 97.3 or 97.6. Unless they just ran to the office, then they're about 112 because they've been working out. Next slide, please. Any kind of mask is better than nothing, even if it's something made at home with cloth that's secured. It does prevent most aerosolized. The office has always been very meticulous and thorough about keeping it clean. Now so, maybe even more so. The staff has been fastidious in terms of washing down every room between patients so that you are protected, and so is the staff. The staff all has adequate PPP, that's the personal protection equipment. So fortunately, we are past that stage when people were really scrounging around to get some sort of covering, which was, in my opinion, quite unacceptable in the United States of America to not have some basic stuff like that. But I'll keep away from that aspect. Washing the hands is obviously very important, and avoiding touching your face. Like if you walk down a flight of stairs or if you decide to take the stairs to the office, very likely you'll be using the banister. It's probably a good idea as soon as you get off the elevator to use our readily accessible dispensers that give you the cleaning solutions, and just wash the hands or use that alcohol prep, the hand sanitizer, and that's available throughout the office. So that's really the most important thing, is you come to the office, which is safe. You have to understand that we go out of our way to make sure it's safe, and that should allay any fears you have of postponing any kind of medical intervention that you think is necessary and that you might be frightened about because of the possibility of contamination. So please feel free that we've taken really every precaution to make your visit with us as safe as possible. Next. Okay, can we move these slides so I can, it's like cut off by the video feed on the right.
I think what you have to do is change your,
Okay.
yeah, so change it to hide thumbnail video, which is the first small rectangle on the left if you hover over the top.
Hover over the top.
Hover, like over what will probably be your head on the left.
You know what? Maybe I could just do this. That's better. That's fine. Just minimize
Okay.
it to 50%. That's fine.
Okay, perfect.
Does that minimize it for you also?
It does not.
Okay, good. Okay. This is pretty much a repeat of what we just did in terms of the social distancing, the protective equipment. The pre-check is the thermal scan and the ability to ask you certain questions. We're constantly, after every room has been occupied by a patient, it's completely scrubbed down, and the sanitation is obviously top-notch. Next slide. These are one of our operating rooms in our office in Garden City. They're fully accredited Quad ASF offices, operating rooms. We also have one in Manhattan, also Quad ASF accredited. I happen to be the surgical director of the ORs. The ORs are always super, essentially sterile environments for obvious reasons. So between cases, they are always completely scrubbed down. So there's really not that much difference between prior to COVID and now. It's always the most rigorous breakdown of the room, scrubbing every conceivable surface prior to the next case. So when you have surgery, that should make you feel comfortable that every room is completely scrubbed down, be it in our office or in any of the operating rooms that we operate in the hospitals. So as I said here, the OR is one of the safest possible places, but considering an environment essentially germ-free. I said essentially germ-free because nothing is 100% perfect. And again, when comparing pre-COVID to the present COVID, there's really not that much of a difference in how the operating room is taken care of. It takes maybe a little bit longer to change cases just because a couple of other surfaces are scrubbed down that normally would not be. But it really is the safest place, and you should feel totally comfortable once you're in the operating room that even though you're asleep, you should feel totally comfortable and at ease that everything has been done to make sure you are protected. Next slide. Interestingly, the time that we were shut down, we were doing teleconferencing or video virtual conferences or consultations, which was fine. You would get to speak just like I'm speaking to you with the patient. They would have specific questions, or if there's a new patient that have specific reasons for the consultation. Clearly there were limitations. It was not three-dimensional. You really could not examine them in 3 dimensions, but you certainly could get an idea of the history and make it suggestions as to what is to be done next, to refer them to places that might have an actual in-house presence. So it was an interesting thing. So you kind of got used to the telehealth and the Zoom meetings as everyone got together virtually. Next slide. So in terms of the breast cancer surgeries during the pandemic, initially a lot of these surgeries were postponed because they were considered not to be essential. The breast surgeons would feel the most comfortable postponing surgeries where the patient was getting neoadjuvant chemotherapy or some sort of a chemotherapy treatment so that the chance of proliferation of the tumor was minimized, because obviously people, as soon as they get that diagnosis, they want the treatment as soon as possible, because God knows what can happen even with a month delay, let alone a couple of months. So that was obviously a very trying period for people that were diagnosed and were frustrated by the fact that elective surgery was basically banished, except for emergent, and these were not considered emergent surgeries. They were certainly very important, but they were not considered emergent. The cases that did go forward tended to be tumors that were a little bit more advanced, or they were not on neoadjuvant, and they were done as expeditiously as possible because other emergent cases had to be done and taken care of, and then a lot of the staff had been taken away from the operating room and placed in the front line for COVID floors and ICU activities. So everything really was brought to a minimum. It was almost like a wartime environment, very much so. So fortunately, towards the middle or end of May, the restrictions for ambulatory elective surgery became lifted, and we were able to get as many of these backlog cases on as fast as possible. What actually happened then was the reconstructions were limited to cases that were done as expeditiously as possible. So in terms of reconstruction options, almost all of it was either delaying the reconstruction completely, so you're just doing the lumpectomy or the mastectomy, closing it and you're done. Or if they had enough time allotted for the procedure, it would be something that was relatively quickly done relative to, let's say, autologous transfer, which is a much more difficult and lengthy procedure. It would be tissue expanders or direct to implant type procedures. And as the last thing I wrote on that slide, when the curve began to trend downward, as I said, the elective cases returned, and we started doing more and more of the backlog cases. Now, as the caseload has eased a little bit, as we've gotten the most urgent cases back on the schedule, the time in the operating rooms has gotten a little bit better, less constricted, and we can start considering doing the autologous procedures. Next slide. So the type of surgery that was performed once the restrictions were lifted, for the lumpectomy or breast conservation type surgery, there was the option of doing simple closure or oncoplastic tissue arrangement, which is manipulating local tissue to, let me just shut this off, local tissue rearrangement to make it as aesthetic as possible. What we were not allowed at that initial time is to do the contralateral case, the contralateral side. In other words, if you're doing some sort of breast conservation reconstruction on the involved side, we would not be able to get the time to do the contralateral side for symmetry just because there were too many backlog cases. And as we go forward, that will clearly improve because the operating time is now opening up to closer to normal. Similarly, for mastectomy reconstruction, it would be almost entirely implant-based, either staged tissue expander with an acellular dermal matrix or direct to implant also with a cellular dermal matrix. And the symmetrizing procedures of the contralateral side would require a second surgery simply because of time constraints. Next slide. Any questions?
So I'm going to stop sharing so it's easier to get to the chat box. So if anybody has questions, please enter them into the chat and I will read them to Dr. Douglas. One question that's come up a lot with the clients that I'm seeing in the support groups is they're having questions about when some of them had surgery like last day open sort of thing, and now they're wondering about when's a good time to come back, and are they able to start scheduling those. And I know you said it'll be a little while maybe for some of those others, but if people wanted things like the deep flap, for instance, when might they be able to start scheduling that?
There haven't been many on the schedule just because the deep takes so long.
Yeah.
But I'm actually doing an autologous case on Wednesday of this week, and the timing is going to start opening up for that as this schedule becomes a little bit more normal. But if someone has, let's say, a tissue expander placed just before everything closed up and they're concerned about what to do next, a tissue expander does not have a ticking time where it has to be addressed. In other words, if they haven't had any expansion over 2 months or so, that's perfectly fine. And the expander can certainly resume as soon as the office hours start up again in that particular office, or the patient feels comfortable enough to start going back. Because a lot of people know that one of the risk factors is cancer. They're immunocompromised to some extent, and it's a very real concern.
Yeah, we've definitely heard that from people saying, you know, they'd like to wait as long as they can if it doesn't feel super emergent. So that's good to know that they can wait a little while if they need to on the if the expansions are put
I
in.
think it's important for, let's say, someone who's now considering surgery, how do they feel protected? So every surgical patient that is scheduled has to have a COVID test 3 to 5 days prior. It was originally 3 days, and I believe they've just increased it to 5 days. But they have to have a COVID test. They will not be operated on. So the COVID test will show, hopefully it's negative, and then we ask the patient to take it upon themselves to self-isolate until the day of surgery. So from the COVID test to the time they get their result to the actual surgery date, they have to self-isolate so that there's no chance of contagion. And then they go to the hospital, they get their pre-surgical testing, and the hospital itself or ambulatory unit is strictly adhering to the most rigorous controls for precautions, for cleaning, PPE, all that stuff. But
That's great.
the COVID test is essential.
That's wonderful. That's good to know. Someone asked, have all reconstructive surgeries resumed at this time?
The answer is yes, they've resumed. However, the ones that demand more time, like a perforator flap, a microvascular perforator flap, that could easily take 10 hours or more for a bilateral, clearly those cases are being selected because it might be a better idea to at least get the patient done by having the mastectomy so the patient at least has a clear head to get that tumor out, and put a tissue expander in to at least hold the space. And then when the OR schedule normalizes, then the tissue expander, which is actually holding the place, can be removed, and the autologous tissue can then be inserted, the perforator flap or something else.
Well, that's good to know that that's an option to do it that way.
Absolutely.
Great.
So
Great.
if the time constraint is such where the surgeon only has, let's say, a 3-hour block, and the patient said, listen, I can't wait any longer. Yes, they can certainly have the mastectomy. They can have a tissue expander put in. They're cutting no bridges at that point. And then they have the option of either proceeding with a stage reconstruction with an implant, or when the tissue, or when the timing normalizes a little bit more and opens up more, they can go to an autologous reconstruction, meaning like a perforator flap.
Great. Can you still meet over telehealth to discuss your options in a case
Absolutely.
that a
100%.
patient has concerns? Great.
Absolutely. Something like a discussion visit, the telehealth would be perfectly fine, because it would just be like we're talking now, and we can go over the options, of course. That would be very reasonable.
Okay.
Because a lot of patients might feel very isolated because they're frightened. And certainly it's absolutely reasonable to feel that way because it's scary stuff.
Yeah. Someone was curious if a patient's husband would be allowed to come in with them or to wait in the waiting room.
We make exceptions for the significant other to join the patient, especially if it's a complex discussion, and having another person in the room really will help them focus and remember stuff, because it's a very trying period. They've just been handed a new diagnosis, and there's a million things floating in their head, and they feel vulnerable and unsafe, and can I get sick on top of this? And that we let the people in, absolutely.
What about if somebody's having surgery? Does the husband need to wait in the car, or is there a waiting room? I know before that was the case.
What we usually do in our office is that when the patient's ready for discharge, then the significant other will be asked to either come up or meet them in the hallway when the person's brought out on a wheelchair.
Okay. Great. Any other questions here? Has your practice heard from any patients who've been awaiting surgery and have lost their health insurance due to COVID? And if so, how are these cases being handled?
I have personally not had that situation. I am not sure what they would do. I mean, they would have to get treated. Maybe they can get emergency Medicaid or something like that based on their diagnosis,
Okay.
something like that.
Okay. And that's something, if that does come up, you can definitely send them our way and we can help a little bit with some of that navigation.
Yeah, or, we do enough cases at these hospitals that we could probably prevail on the administration, although I can't guarantee it,
Yeah.
to say, listen, this person has a major diagnosis, they have to be treated. You're not going to turn them away with a cancer diagnosis, are you?
Yeah.
You wouldn't like to see that in Newsday, would you? So there's ways we can handle stuff like that.
Great. Raina, you raised your hand?
Sorry, you already answered my question. Thank you.
Oh, okay. Just looking at the box here to see if there's other questions.
So I think the important thing, the important takeaway is that patients should feel safe. We're doing everything in our power to make them safe and to get them through this difficult time and to at least get reconstruction moving, because that's very important for them to have a feeling of just that which is taken away is being replaced as best as we humanly can. And this will improve. Of course it will. And the time of the surgeries will improve in terms of the amount that we're allowed to do larger cases. And we'll just move from there. But again, they should absolutely feel safe. They've really gone out of their way to make it as good as possible. I mean, I was nervous first going back because you don't know.
Yep.
We didn't know much at all about what this virus was doing. We figured that anybody within 20 feet is susceptible, but it's not as infectious as we once thought. And the masks have been really, really excellent for preventing this stuff. I mean, look at these countries that you see pictures of everyone in the street with masks, like Japan and Singapore and South Korea. And then you see people in Oklahoma, and that's where all these cases are surging because they're just saying it's not going to affect us.
Yeah, I think that's a good takeaway too. Is the importance of the mask, and I appreciate that was on every slide that you had. That's the thing that we know for sure. Will help the most, and I appreciate how open and honest you've been and how sensitive you've been in this conversation, thinking about the needs of your staff and thinking about the needs of the clients and understanding the very real fears that people have surrounding
Absolutely.
this.
It's our fears also. I mean, we all want to stay healthy. This is uncharted territory.
Yeah, absolutely.
And you really can't turn a blind eye and say, yeah, it'll never happen to me. That's not the smartest thing to do.
Yeah.
But the patients, if they need surgery now, it's a safe event for them, and they really shouldn't delay getting any kind of medical help or symptomatology that they have because they're fearful of going to any kind of a doctor's office. Forget breast reconstruction or a breast diagnosis, just anything. They really should take it upon themselves to not ignore symptoms because of fear. Because the offices that are open now really take every precaution to make you as safe as humanly possible.
That's really important. I think that's coming up for a lot of people as well. And I think on our end, we're worried about what will happen with breast cancer, with people waiting. And so that's good to hear what you know. Another question is, are the surgeries taking place at your office or at local hospitals, or a combination?
Right. Our office charter is basically set up for non-insurance type cases. It's as unfortunate as that is, because we would actually do the cases less expensively than the hospitals would do it. But there's lobbying groups that prevent the office-based surgeries from doing a lot of reconstructive cases that are insurance-based. They'd rather pay the extra money, and the hospitals lobby for it. So a simple answer is our offices would not be doing the breast reconstruction, although we've been petitioning various legislative agencies to wake up and realize that, come on, an operating room is an operating room. We're fully accredited. Let us do it. We have the operating time available, although it's been kind of a crush on our getting our cases back on also. But yes, fundamental insurance cases are hospital-based.
Okay. All right. Do you happen to know if the visiting policies are similar at the hospital as to what you guys are doing in the office, as far as patient, spouses coming in with
It's
patients
pretty
and
much the
things like
same.
that?
It's pretty
Okay.
much the same. Like before, you would see a filled waiting room of family. Not
Mhm.
now.
Okay.
They're told, drop the patient off, bye. And then they're given a heads up phone call when they're about to be discharged, and then they
Okay.
meet up again. But
Okay.
it's a whole different environment to maintain and keep the amount of possible human contact down to a minimum.
Yeah. I, I as a non-doctor, as someone who would be going to do these things, I feel really comforted by that everyone's doing the best they can to really keep people as safe as possible, including the not having extra people in. I think that's so important.
Absolutely.
Yeah.
I just think that from a safety point of view, the masks are super important. I don't think anybody should be letting their guard down and say, I know how frustrating it is.
Mm-hmm.
When we finish surgeries, one of the routine traditions is to rip off our gown and gloves and tear off our mask because, wow, it's refreshing. It doesn't happen now. So the mask stays. And some of those N95s, I don't know if anyone's had the privilege of wearing an N95. They're not the most comfortable things in the world, but it is our new reality. And I believe this will be going on for a long time.
Yeah. Well, thank you so much looks like we don't have any other questions. And I want to be respectful of people's times. I know Zoom after a while can feel like you're being held hostage a little bit. So if there's no other questions, we'll just give you a big thank you. And thanks so much for taking time out of your schedule to do this, to give our patients a little bit of reinsurance. This made me feel better. And I feel grateful that I can pass this information on to my clients and refer them to the video that'll be on YouTube tomorrow to get these, these answers for themselves. And to all the participants, we're going to send out an email evaluation, and you can also, if you have questions that you come to like mine do right before you're falling asleep, you can put the question on there and I'll forward it to Dr. Douglas in his office and we'll get back to you.
Absolutely.
All right, I'm going to stop the recording so I don't forget.